Dans les années 90, le kératocone était le problème, was the problem before LASIK, et on a résolu le problème avec des indices, Bellin Ambrosio or, for example, Gatinel in France. So, in my opinion, we need to have something like that for dry eye. The criteria of TIFOs have 6 years now, and national societies try to make some new dry eye diagnosis, but I think it's not enough. So our French group, I presented this morning, we work on establishing a new criteria, we could call eTAO. For E, it's the epithelium, and you have the 4 criteria. I do it quick. So we need that because we need an index to help diagnosis and monitoring patients, to establish the most effective dry eye treatment, to prevent the problem of LASIK before, dry eye before and after LASIK, the problem of corneal toxicity of eye drops for glaucoma, and we discussed this morning the best IOL for cataract surgery between multifocals or EDOF or monofocals, and also in contact lens adaptation. So these 4 criteria, do you think they are relevant, Serge? Or that's missing something for you?
No, it's a good, as I told you this morning, it's a very good approach for the lead disease, of course. Not only dry, not the whole problem of dry eye, but for the lead disease, it's very interesting. And I'm very interested in the telangiectasia because this is not very well explored. So we have to learn about this.
At least, yeah. Okay. Carlos?
No, I think you are doing a great job, so congratulations. That's first. And of course, we need to objectivize more and more the data, because sometimes someone use some technology, another technology, and it's difficult to manage all these data. So I think that we have to objectivize the different machines, how to measure, how to understand that results, just to talk about the same for everybody. So I think it's the first step, and congratulations.
Thank you.
Of course.
Luca?
Yes, I think that we can separate the how to do a good diagnosis and how to classify our dry eye patient, and the other thing is to find the causes of dry eye. So I think that if we want to do a perfect or a very precise diagnosis, we need to check all the issues that you suggested and the issues that are in the definition of dry eye by TIFOS. If you want to check, of course, also the causes of dry eye is another matter. So in this case, we must go deep inside, of course, all the body of our patient, all the systemic, I mean, the general health of our patients. So.
Okay. And Rolando?
So I think you're on the right track of trying to find objective ways that we could all understand. So that if I see a dry eye patient here, at my place, and I send them to you, and you see them immediately, you can get there. The thing that I would mention is this is happening in all of medicine, and we have to start thinking about as dry eye specialists is the use of AI. Actually feeding this information that we're getting, like a mybography, and having AI rate what the dysfunction is and how bad the dysfunction is and what treatments work to get them from point A to point B. I've got my confocal, we got our confocal about 2 years ago. I love those pictures because they're immediate and mild, moderate, severe. They all have changes in confocal. And when you're talking about surgery, that's the other study that we're doing is what is the effect on the cornea post-surgery. And I can tell you any surgery that we do is affecting the cornea.
Yeah.
Some surgeries more than others, and it's changing my surgical patterns because of it.
Thank you.
Just one comment about the how to study the dry eye patients, and I think it's important to incorporate new biomarkers.
Yeah.
You know that we are working with the immunogenetics, and we try to launch a system very easy, and also if it's cheaper, better, just to detect some of the cells you have mentioned, the CD4 and the CD, the 17 that are in the middle of the inflammatory process. So you will have to detect these biomarkers. I think that will be very interesting just to know the inflammatory reaction of the ocular surface, just to decide the best treatment, and also to control the follow-up. I mean, if the treatment it's working, if it's effective. So I think it's moving to the future, thinking about the biomarkers and the immunogenetics.
And speaking of that, so now there's a study out of Australia where Dr. Downey has actually using confocal can detect T cells in the cornea. So what we need to do is we need to talk to the companies and say, we want confocal. Because it's expensive for them to make, but if they realize that we all want confocal.
The confocal will be in your OCT in 2 years. Yeah.
You know, about confocal, you mainly detect dendritic cells, but T cells are very small, and it's very difficult to distinguish these cells. So mainly the inflammation that we see is dendritiform cells.
Yeah, I agree.
Alors, je vais vous présenter ce qu'a dit Carlos, qui est important. Carlos travaille à l'hôpital et il a la chance d'avoir un service d'immunologie qui est dans la porte d'à côté de son service.
C'est vrai.
Et donc, il a la possibilité de faire analyser les larmes et d'étudier plein de biomarqueurs et plein de gènes qui se surexpriment lors de l'inflammation. Et donc, il mène des études extrêmement intéressantes. Mais c'est vrai qu'au quotidien, c'est beaucoup plus compliqué que dans un hôpital. Mais si tu arrives à mettre au point quelque chose de simple, un test simple, qui effectivement, on prend une larme et tu donnes un résultat, comme on fait pour le test Covid là maintenant.
C'est l'objectif, de faire quelque chose de très petit, très facile pour voir ce qui passe à la larme de le malade.
Donc ça, c'est
peut-être le futur next.
I have a question for you, Pablo. So your classification, so as I understand it, it's mainly related to MGD and lead function, and to see what is the effect of IPL or lead treatments. But you intend to use this classification as a whole ocular surface marker?
Yeah.
Or so because with this classification you don't have the quantity of tears?
No.
You don't have the friction?
No.
You don't have the
the friction you have with the E.
Yes, with the EOCT.
Yeah.
But you don't know about the stability of the tear film.
No, you're right.
And you cannot distinguish you know about the meibomian part, but what about the mucus part of the dry eye, which is part of the unmet need, because we don't have anything to treat mucus layer deficiency.
No, you're right. But the problem was
Cyclosporin can treat the mucus layer. So, Flugfelder did a paper years and years ago showing goblet cells increase with cyclosporin. It's been 10, 12 years since he did that paper, but I mean, if I see, so I'll tell you, I just saw a patient, they had a procedure called Eyebright, where they had red eyes, the doctor took all of the conjunctiva. So she doesn't have a mucus layer. She has some conjunctiva here and here. And so one of my treatments for her is cyclosporin to try to build up the goblet cells. But does IPL do that? I don't know. But
there are some studies about IPL, and they showed, I think it was a study on IPL in surgery, cataract surgery, and they saw that they showed that there was an increase in the goblet cells. So it can have an effect, but the main examination for mucus we don't have.
No, yeah, you're right. I think the eTAO is a first step, and we are working to have something perfect perhaps in few years.